Hello and welcome to today's webinar featuring Deborah Fein. I'm Claire Cameron, Engagement Editor at Spectrum, the home for autism research, news and analysis. We'll begin the presentation in a moment, but first, know that we'll be fielding questions at the end of today's presentation, but you can ask them at any point during the session. To ask a question, submit them via the chat window to the left of your screen. And as always, I'll note that if there are any members of the press tuning in, you can only report information presented during this webinar if that material has already been published elsewhere or if you have first obtained express written permission from the presenter. Today's presenter, Deborah Fein, is a clinical neuropsychologist who has been doing autism research since the late 1970s. She is currently Board of Trustees Distinguished Professor in the Departments of Psychology and Pediatrics at the University of Connecticut. Professor Fein has authored over 150 articles on autism and has served as the Secretary for the International Society for Autism Research, as well as on the board of the American Association of Clinical Neuropsychology. She is the author or editor of 3 recent books on autism research and is the co-author of the widely used autism screening tool, Modified Checklist for Autism in Toddlers, known as the MCHAT. Her current research focuses on autism screening, outcome, and parent training. Welcome, Professor Fein.
Thank you very much, Claire and Spectrum. I'm very happy to talk about optimal outcome in ASD today. So just a couple of things. I will probably skip some of the data because I have a lot of data in here, but we are happy to make all the slides available, which you can get by either emailing Claire or emailing me, and you can see my email address on that first slide. So let me just say one quick word about what we mean by optimal outcome. So as you all know, what we want for our children, our patients, is to be happy and healthy and to have as meaningful work and relationships and leisure activities as possible. So when we talk about this kind of optimal outcome, this is only one possible outcome that would be successful. So I have no financial conflicts of interest relative to this work, and our optimal outcome grant was funded by NIMH. I did want to put in a plug for a book that just came out in December, Guilford Press, and this is for EI providers, but also mainly for parents, and it's a series of activities that they can do to try to stimulate development. And so you might want to take a look at that at Amazon. I think we've, I hate to be immodest, but we have done a really great job with this book. Okay, so autism has extreme heterogeneity, as you all know, in many dimensions of functioning. And one of them that has gotten not much attention in research, although some, is the heterogeneity in their outcome. And that can be 2-3 years after diagnosis, can be adolescence, can be adulthood. And there's extreme heterogeneity in the outcome, from individuals who need lifelong care to individuals who are very successful at relationships, marriages, families, careers. And Ewer and Rudder, I'm sure you all know Mike Rudder, proposed that clinical course should be studied as an important dimension of variability that might reduce the heterogeneity and allow us to get more biological findings if we have a phenotypically more homogeneous group. So this specific outcome that I'll be talking about is about losing the diagnosis. And there have been several key recent papers in addition to the work from our lab. One of them is Anderson, Liang, and Lord, Kathy Lord, published in 2014, where they followed longitudinally 85 autistic children from age 2 to 19, and 9% of them lost the diagnosis and were functioning in the average range of IQ, and they called these very positive outcomes. When they went back to their 2- and 3-year-old data, they found that this kind of outcome was predicted by reductions in repetitive and restricted behaviors from age 2 to 3, higher initial IQ, and greater participation in early treatment. So this is a very important study. Another one is Fountain, Winter, and Bearman in 2012, where they followed a very large group of children. I believe they were all in California from age 2 to 14, and they developed 6 trajectories. And 10% of their children were what they called bloomers. And this is one of their graphs. So you can see that line for the bloomers where they're showing very rapid progress. And in communication, they're really ending up in the normal range of functioning. They also showed similar graphs in socialization and restricted repetitive behavior, and in general, blooming in one category was associated with blooming in the other. So it tended to be the same kids who were blooming in all these categories. It was also associated with high socioeconomic status, which is maybe not a major surprise, non-minority families, and no intellectual disability. And then 2 more that I want to mention that are really worth looking at. One is by MacDonald et al., and they followed 83 children who were either 18 to 23-month-old, so just before 2, just before 3, and just before 4. And they all were placed into the ABA programs of the New England Center for Children, which is where Becky MacDonald works, and they measured these outcomes, and what they found, I'm oversimplifying a little bit, but not much, is the kids who started therapy before the age of 2 improved most, followed by the kids who were 2 to 2.5, followed by the kids who were 2.5 to 3. So very strong evidence for the importance of starting early. And the last paper that I want to mention is Sally Rogers et al., where they took their ESDM intervention and they modified it to be an infant start model. And this is published in JAD. And they took 7, it's a very small sample, but it took them 3 years to get this sample, 7 symptomatic infants, aged 7 to 15 months. And they put them all in this parent-implemented infant start intervention, and 5 of them did not have autistic features at 36 months. 1 of them looked autistic, 1 of them looked like they had an intellectual disability. And they compared them to several comparison groups, and these kids did the best. So now I'm going to move into our current study. So we were funded by NIMH, and here you see our faculty collaborators, 2 very close colleagues who did recruitment, and then you see the graduate students who worked on this or are still working on it, most of whom now have their PhDs. The purpose, we really had 3 purposes to these optimal outcome studies. So one is to find evidence to support the existence of this subgroup who really lose their diagnosis, and not only lose the diagnosis, but really are functioning pretty much indistinguishably from typical kids who never had a diagnosis. And then to provide a detailed description of them, including what they looked like as young children, and then to see if they had any possible residual problems in any domain that we could identify, and then to try to start exploring how this could happen. What are the mechanisms? So for that, we got some biological data and intervention histories. So this is a study that is in press that one of our graduate students did, and she looked at kids that we diagnosed between at age 2, and then she looked at them at age 4. And she had 207 children, and 83% retained their ASD diagnosis at age 4, which is in the ballpark of what we've seen in other studies. And 9%, so we're not calling this optimal outcome because they're only 4 years old, but optimal progress, where they had a clear autism diagnosis at age 2, but no ASD at age 4. When we looked back at their age 2 evaluations, there was no difference in how old they were when they were diagnosed and therefore referred to intervention. No sex ratio differences, no differences in maternal education, ethnicity, or cognitive functioning. And there were significant differences in the initial diagnosis. So we were using DSM-4 at the time, and 16% of the PDD-NOS kids, 8% of the autistic disorder kids, and none of the kids who had autism but very low mental age equivalence moved off the spectrum. They also had milder symptoms, and milder symptoms in particular in social communication, stereotypies, and sensory abnormalities. Okay, so no tremendous surprises. So among these prospective studies, the predictors of optimal outcome in general seem to be milder autistic features, more ability to interact with typical kids, fewer repetitive behaviors, better motor skills, and their behavior in daily life was more predictive than formal testing. So we have we have a couple of kids in the optimal outcome group whose parents have written a book about them, and therefore they are public about their identities. So I think if you just Google Jake Exkorn, E-X-K-O-R-N, you will find a link to a Nightline segment on him, and also UConn did a segment on him. So if you just go to uconn.edu and put in recovery from autism or something like that, you will probably get video clips of Jake when he was 2-3 years old and was getting intensive ABA, and who was clearly quite autistic, and now he is sophomore or junior in college and doing really well and in every respect. So the inclusion criteria, so how do we define optimal outcome? So we had optimal outcome, high functioning autism, and typical groups. And they all had to have verbal, nonverbal, and full-scale IQs 77 or above, which is 1.5 standard deviation, so within what could be considered the normal range. No major psychopathology that would impede participation, no severe sensory impairments, no seizures, no Fragile X, and no significant head trauma. And then additional inclusion criteria for the optimal outcome subjects was a documented ASD diagnosis made by a physician or psychologist specializing in autism before the age of 5, and an early language delay as defined in DSM-4, and then a report from before the age of 5, and we took out all references to the diagnosis, the summary, the recommendations, and these were reviewed by Dr. Barton, who's one of our clinicians, mixed in with foils to verify that they had definite autism features at a young age. And then no current ASD as per the ADOS and best estimate clinical judgment. They also had to have violent communication and socialization also within the normal range. We didn't include daily living because I think daily living is really up to the parents. So I've had lots of parents where I say, does he make his own bed? Does he help with chores? Oh, of course, everybody in our family does. And then you have other people who say, well, no, we're really focusing on language and social communication. So we put in the things that had more to do with the kids functioning and less to do with parent demands. And then they had to have full inclusion in regular education with no one-on-one assistance and no social skills services. We did leave it that they could have services for attention or for dyslexia because we wanted to see if these kids wound up needing that, but no social skills services. So this is their basic functioning, and if you just look at the last column that shows you what is significant, the only thing that was significant was verbal IQ, and you can see that the high-functioning autistic individuals had an average of 105, and the optimal outcome and typical had a verbal IQ of 112, but everybody was in the normal range. This is their ADOS scores, so in communication and in social functioning, and you can see that the HFA group, which is in white here, were quite elevated and met criteria for ASD, whereas the optimal outcome and typical kids had very low scores and well under the diagnosis. Then we looked at Vineland socialization, and again, you can see that the HFA individuals were just below 80 on average, and the optimal outcome and typical individuals were solidly at 100. I should mention their age, which is probably on that basic functioning slide, but we started with an age range of 8 to 19 because we had done a few prior studies on kids 5 to 9 and then 9 to 15. And those are studies where Beth Kelly is the first author. And so that was our plan. And then we started to get emails from individuals and from parents. My kid goes to Brandeis, my kid goes to Brown, and they really want to be in the study, and they, were definitely on the spectrum. So we allowed the age to go up to 21 because we really want to see how these kids were doing. We did a lot of basic phenotyping. So this is a paper that came out in 2015, and Alyssa Ornstein found a likability scale that we modified very slightly, and we had undergraduates look at clips of the ADOS and rate a whole series of, how popular do you think this person is, and would you like to have them for a roommate, and do you think you could be a friend of theirs, and a whole variety, and then overall likability. And you see that the high-functioning autistic group is much lower than the other two, and the optimal outcome group was actually a little higher than the typical development. And I'm not sure why this is, but I think they really were taught to interact with a lot of different kinds of individuals. And so they wound up looking, kind of outgoing and friendly. And I think some of the typical kids, were kind of shy when they were doing the ADOS. But in any case, you can see that there's no residual problem in likability. This is a small study, but I just found it fascinating. So Christy Irvine, who was one of our language-focused graduate students, did a study on these, on the audio tapes, the videotapes that we had of these three groups. And it turns out, I had no idea about this, but it turns out that filler disfluencies, like when you say, so if I'm talking and I say, oh yeah, I know what I was going to say. Or I say, oh, let's see, I'm talking about this, but now I'm going to, okay, so there's and there's and they serve different communicative functions, at least in English. So it seems like is more inner-directed, where you're trying to prime your thought organization or your word finding, and is more social, and you're communicating to your listener that you're having some word finding difficulty, but you're not giving up your turn as the speaker. You're holding the floor. So we thought, well, this is a really nobody was ever going to work on this in ABA with these kids. So she, and now I'm going to get really self-conscious about and So Christy looked at the frequency of in the transcripts, and she found no significant group differences. And furthermore, there was no correlation between the frequency of and any language or social measure. But if you look at the frequency of the typical and optimal outcome individuals produced more than the high-functioning autistic group, and they were not different from each other. And within the high-functioning autistic group, a lower rate of was associated with worse social communication. So it really was a speaker-oriented disfluency. We also did a study of residual problems in descriptions of paintings. So we had them describe classic oil paintings, and as you probably know, there's a difference in the proportion of global details versus local details that is often produced by individuals who are very verbal but have high-functioning autism. And they tend to produce more focus on the little details that are not central. So instead of saying, there's a girl and she's sitting in a chair and she's dozing, they'll say, she has red shoes on and she's wearing a yellow dress. So when we look at the global details versus the local details, everybody gives more global details. But the high-functioning autistic individuals gave fewer global details and more local details. And the optimal outcome individuals were not different from the typical individuals. Another thing that we looked at was psychiatric comorbidity. So there is a lot of psychiatric comorbidity, as I'm sure most of you know, in autism. And in particular, anxiety, depression, tics, and specifically within anxiety, some generalized anxiety, some phobias, and a lot of attention, ADHD kind of problems, and some ODD. I don't know of any evidence that there's real psychosis that's higher than in the population at large. So we were particularly interested in whether the optimal outcome individuals had psychiatric comorbidity that looked like that in high-functioning autism. And that would have implications for either shared pathophysiology or some of the core features, and then some things that may need treatment. So this is the current internalizing disorders, and I just put in red the significant differences. So the only difference was in specific phobias, and you can see the frequency there, where optimal outcome and high-functioning autism had more phobias than the typical kids. And current externalizing, there were two things that were significant. One was ADHD, where, again, the optimal outcome and high-functioning autism groups were not different from each other, and they had more ADHD than the typical population. And then in tics, the high-functioning autism kids had more tics in their history than the typical or the optimal outcome. And then if you took a history and you looked back, you also found specific phobia, same kind of finding, and major depression. And with major depressive episodes, it was really the high-functioning autistic kids, not the optimal outcome. And then if you looked at past externalizing, it was, I didn't put it in red here, but it was ADHD, very strong differences, and ODD, where, again, it was the HFA kids who had some cases of ODD, and then tics at the bottom, where, again, it was both of the clinical groups, optimal outcome and high-functioning autism, had a history of tics even though by the time we saw them, the tics had largely abated in the optimal outcome group. So the HFA individuals had the highest level of current and past comorbid psychiatric disorders. In the optimal outcome kids, the psychiatric symptoms did seem to abate over time as their autism symptoms abated. And the most frequent in the optimal outcome were phobias and ADHD. And, one possibility is that ADHD is hard to treat. There's medication, of course, and it works for a lot of kids. But to really remediate attention problems without the use of medication and very structured behavioral treatment, it's very hard to treat. And it's also possible that that is less often a focus of treatment because people are really working on academics and social interactions and mood. So I think that we don't really know why these are. The phobias were kind of interesting because Dr. Barton, who's our director of clinical training, noticed that the phobias were actually a little different in the optimal outcome kids than the few that we saw in the typical kids and also that you see in the literature. And they were things that might have evolved out of their sensory sensitivities. So they were crowds, they were babies crying, so they were things that might have been sensitivity to auditory input when they were younger. And they also had tics, but mainly in the past. The HFA group also had ODD, OCD, tics, depression, and some subthreshold generalized anxiety and social phobia. Okay, so moving on to the possible mechanisms. So the first thing that we looked at was the intervention. So what were their histories of intervention? Now, of course, it's much better to do this prospectively because these individuals might have been, as old as 21, and we're trying to get from the parents an accurate intervention history from the time that they're 2 or 3 or 4. But we found, and if we had found, subtle differences, I probably would not have put any weight on them, but they were pretty dramatic. So, and this is a paper also by Orenstein in the Journal of Developmental and Behavioral Peds, 2014. So we looked year by year, actually 6 month by 6 months. So at 1.5 to 2, I put in yellow here, the only significant difference was that the optimal outcome kids had some developmental therapy, which could have been DIR or DRI or floor time, but not too many of them were getting even that. It was just 16%. Then when you get to 2 to 2.5, you start to get really big differences. So there still is a developmental therapy difference, 0 versus 20%, but the really big difference is the kids who started getting ABA between 2 and 2.5. So you can see it's only 4% of the HFA and 40% of the optimal outcome, which was a very significant difference. And then from 2.5 to 3, it's even a bigger difference, with 7% of the HFA kids getting ABA and 56% of the optimal outcome kids. Same thing in the first year of preschool, 3 to 4, except that now you get more of the HFA kids getting ABA. And then the second year of preschool, there's 3 differences where, again, the optimal outcome kids are getting kind of more of everything. And the biggest difference with a p-value of 0.001 was 72% getting ABA and 25% of the high-functioning autistic kids. This is medication, ever getting medication, ever getting antidepressants and ever getting atypical antipsychotics like risperidone. And 3 of them were significant, and it was all, as you might expect, that the individuals with autism were getting more of the medication. And then just to show you visually what I really just talked about, this is participants receiving any intervention, and you can see that from 2 to 2.5 and 2.5 to 3, those are the biggest differences. And then when you look at the percent receiving ABA, you can really see strikingly visually the differences, and they were significant at every age from 2 to 5, but you can see that from 2 to 2.5 and 2.5 to 3 are the biggest differences. Okay, then the second study where we were trying to look at head circumference was a study where we looked at head and body growth in infants later diagnosed with ASD, and we looked at the optimal outcome group and the still autistic group. So as you probably mostly know, there is some replicated studies, although not every study has replicated this, that individuals with autism tend to start at birth with a head circumference that's average or even a little small. And then they tend to accelerate their head circumference, which is reflecting brain volume. I just looked up, I thought by the time the sutures close, it can't be very reflective of brain volume. And one article that I read in a medical journal said there's a high correlation between head circumference and brain volume until age 6, which kind of really surprised me. But anyway, what they tend to show, the autistic group, is an accelerated head growth and sometimes body growth, although that's more controversial. And then it slows down by the time they approach about 2 or 3. And even though they may wind up with large heads, it tends to regress back to the population mean. So we hypothesized that the kids who could really move off the spectrum and respond so dramatically and so quickly to intensive early intervention, that they might have just average head size. And that is not what we found. So this is the main finding. So the horizontal line that goes across is the age, and this is the Z-score as put out by the CDC. So this is the average head size for these ages. And we had some local Connecticut control, so that's the bottom line, the dashed line, and it was interesting that they showed the same kind of pattern, although much less. And I think this really reminds us that we can't just always use the CDC norms, we have to use local controls. And then the intermediate line there is the kids who had autism that was stable, where they stayed on the spectrum, and then the optimal outcome kids are the top line. So there was not any significant difference between the ASD stable and the optimal outcome. But you can see that, if anything, the optimal outcome had even a little more head growth. So whatever is biologically different about these kids, it's not reflected in the head and brain growth early on. Okay, and then the last mechanism study that's actually, it's not in press anymore, it's 2016. We did structural and functional MRI on a subset of each of these individuals, and the question that we were asking was, to the extent that their performance is normal, the optimal outcome individuals, are they using the same brain regions and activating them to the same degree as the typical kids? Or do they still look like the autistic individuals, or do they have some unique pattern? Then we're also looking at structure. So we have several grad students right now who are looking at functional connectivity and structural connectivity and brain volumes, particularly in the language areas. So what we found with the functional results, and I should mention there's a really nice paper by Peter Mundy and Croson where they suggest that if you have successful early treatment, that you get neural normalization. So our prediction was that the optimal outcome individuals their brain function might look more like the typical individuals. Dawson reported normalized EEG when she looked at 2 years of treatment with the Early Start Denver model, and then she had them look at faces versus objects. And for those who did really well, their EEGs were normalized. But I think this is really reflecting attention to faces. So it doesn't really tell you what areas of the brain they're being used. There is some literature on other conditions like successfully treated dyslexia and some successful intervention for mild cognitive impairment associated with aging. And some of these suggest a combination of normalization and compensation. And Gwen Eden has done a lot of very elegant work on this. So what we used was a reading comprehension task that we adapted from Canna et al. They kindly gave us their stimuli. And the subjects just had to make true-false judgments about sentences, and we found no group differences on accuracy or reaction time. And then we looked for brain areas showing normalized activity, which would mean that the optimal outcome individuals showed patterns like the typical, and the HFA group would be different. And then we looked for areas showing what we hypothesized would be compensatory activity, where the optimal outcome individuals were showing more activity than the other two groups, and then autistic activity, where the optimal outcome would look like the autistic individuals. And we use standard fMRI parameters, and I refer you to Eichsty et al. 2016 for those. So we had, this is just to show you that the task did what it was supposed to do. So it was a reading comprehension task, and the orange was activation. The blue shows you deactivation, and you can see in the orange that there's a broad bi-hemisphere network, including, of course, Broca's and Wernicke's area, more on the left, but bilateral. And then the bottom two pictures are the medial surface, and you see a lot of blue, which is deactivating what people are calling the default mode network. And so then we looked for brain areas showing residual ASD pattern. And there were some of those. So on the left, there was dorsolateral prefrontal cortex, the IPL, in particular supramarginal gyrus, the posterior cingulate, and then on the right, superior and middle temporal gyri. And I'm a big believer in the Sherlock Holmes dictum, which is that you don't hypothesize in advance of the data because you start switching your data to fit with your theory. So I would love to see this replicated in a bigger group before we start really getting into why these particular areas. Then brain areas showing what we're interpreting as compensatory, and it might not be compensatory, but where there is more activation in the optimal outcome group. And here were all the left areas that were more activated than in the optimal outcome than either of the other two groups. So precentral gyrus, inferior temporal gyrus, superior temporal gyrus, the precuneus, middle occipital gyrus, and parts of the cerebellum. And there were quite a few on the right as well. So you can read these at your leisure. So some of these are clearly language areas, and some of them seem to be motor areas. But in any case, there were quite a few on both and left right-sided where there was more activity in the optimal outcome group. And then we looked for normalized functioning, where the OO group was showing activation that was like the typical group, and we found none on either side. So what we found was that the optimal outcome in ASD groups had similar activation in frontal and temporal regions and posterior cingulate, and both of them differed from the typical group. And the OO group showed a lot of heightened activation in numerous left and right-sided regions, which we are presuming is compensatory, but that's a hypothesis. And we really saw no evidence of neural normalization. So to give you a summary of all the optimal outcome results so far is that some children with ASD can reach typical levels of social, academic, executive functions, and communication. And I've only shown you some of our papers. We have more about academics and executive function. The optimal outcome individuals got earlier intervention. In particular, they got more ABA. And there are some residual psychiatric vulnerabilities in some of them, especially in attention functioning and phobias, but not as much as in the autistic group and tending to abate over time. And to the extent that you can generalize to brain volume from head size, no early brain growth differences between the optimal outcome and the autistic. And then, to the extent that this is replicable, there's some preliminary evidence of neural compensation, but not normalization, despite the fact that they got very early intervention. So these are some of the other findings that I mostly talked about. The repetitive behaviors, we have a paper on that you can see at the bottom here. They had almost no residual repetitive behaviors, but significant psychiatric comorbidity. Okay, so some of our future directions would be really great to know what % of the kids who are diagnosed early have this potential for this particular kind of outcome if they get early, intense, high-quality intervention. I think the current, if you look at all the prospective studies, it suggests a pretty wide range, but something in the area between 9 and 20%. So we are still talking about a minority. And what were they like at age 2? Can you predict what has this outcome as a possibility? And then what do they look like in adulthood? So we would like to follow them now into their 20s, so 20 to 30, to see what is their academic achievement, what's their social achievement, what's their academic achievement compared to siblings or compared to matched for SES. And then what are the individual patterns? I would love to follow some of these individuals like every month, which of course is not going to be practical, but what remediates first? Is it that they become more socially attuned? Is it that they become more compliant? Does their language have to start kicking in? So what are the patterns of behavioral change? And then, of course, if you could do fMRI on a 2-year-old, that would be great. And And then, really important, what are the biological characteristics? Do they have any genetic similarity among them? Okay, so it's 3:45, and what happened to? Okay, I did want to show you. This is just about a minute and a half of what a kid looks like at 2 when they're severely autistic, and then at 5 when they're not.
Beautiful. That's standing up like this. Okay, let's try it again. Stand up. That's standing up. Say juice. Juice.
Yeah.
Nice try. Look at Georgia. Say juice.
Yeah.
Juice.
Yeah.
Good. That was a much better try. Which one? Lollipop. Yeah, where's Georgia? Thank you. What's your name? Say Wells. That was better. What's your name? Wells. How old are you? 2. How old are you? 2. I like it. Do this. Mwah. Beautiful.
Here, take a picture with you, Cameron.
Oh, okay.
It's upside down.
Motion picture, okay.
It's upside down.
Okay.
Put
I gotta be on.
walls through here.
All right.
George has to take your glasses off.
All right.
But wait.
Okay. Okay, I got you.
Okay.
All right. I got a motion picture camera though. See, I can keep it going. I should be filming this. Got a picture of you taking a picture of me.
I took a picture of you laughing.
Okay, good. That's always a good shot when you somebody's laughing.
Maybe I could take a picture of you.
Mm-hmm.
Okay.
Okay, so I guess we can take questions now.
Thank you so much, Professor Fein. So we do have a couple of questions. One is this kind of optimal outcome possible without early intervention? And how does that apply to people who don't come to clinical attention until later in life?
I wish I knew the answer to that, and I don't. I have heard individual case reports of people who, you see a film of them and they look pretty autistic, and then they didn't get anything but very cursory is probably not the right word, but not evidence-based or not intensive intervention. But there's not many of them, and I wouldn't, if I had a choice, I wouldn't want to do that study. And that's really one reason why we wrote this activity book, because there are so many people who don't have access to very good intensive intervention. There's plenty of people in the United States who don't have access to that. It varies state by state and town by town, and then many countries, probably the majority of countries in the world, where they don't have this. So not that parent implemented intervention is as good as professional, board certified behavior analysts, supervised therapists. It's not as good, but it's hopefully better than a minimal amount. So we put a lot of things, we explain the principles of ABA in that book, also talk about the importance of attachment, and then we give a lot of examples of things that parents can do just as part of daily life that would hopefully have some of the same effects.
Did you do any genetic testing any point on the children you're following?
No, and we've thought a lot about that. So very big genetics institute that's part of the UConn Health Center, and also some medical geneticists at Connecticut Children's Medical Center. But here's the problem. When I talk to the medical geneticists and I ask them, take a random sample of individuals with autism, what % of them can you usually find a genetic finding that is likely connected to their autism? And the answer is usually in the area of about 20%. And then I ask them, are those the lower functioning kids who have intellectual disability along with their autism, like kids, with Rett syndrome or Fragile X or 22q deletions or some defined genetic syndromes that often have autistic features but also intellectual disability? And some of them say yes, and some of them say they're not sure. But how many individuals with optimal outcome would we need to really identify when they're all high functioning in order to find any commonalities? So, we've estimated, 500 or something, and we're not going to find those. So I would love to do it, but I think it's going to be a low-yield study, at least in the present state of knowledge.
Did any of the children that achieved optimal outcome have any learning disabilities?
Yeah, so they certainly did. So a small number of them had actually the opposite of dyslexia, which is hyperlexia, where they're fascinated by letters and numbers and they decode language at a precocious age, but with impaired comprehension, as opposed to dyslexia, where they really have trouble decoding. They have trouble matching the letters to the sounds. So we did have a couple with dyslexia. We had a few more with hyperlexia. We had several that had writing and math problems, which go along with ADHD frequently. So we do have a paper on that, and I believe the first author is Mike Stevens, and it's or maybe it's Eva Troy, but it's academic functioning in individuals with optimal outcome. And she describes in there how the kids did on decoding versus comprehension of language and on math calculations as opposed to math concepts.
Did you see any gender differences in terms of the children that had this?
Yeah, that's a really wonderful question too, and the answer is no, but our sample is still pretty small. So we had, I think, 35 and 44 in the OO and HFA groups. So you'd need a pretty substantial sex difference for it to be significant. So I don't know the answer to that. If there is a sex difference, it's small. In other words, is it better to be a boy or a girl? And one of them might have a better prognosis, but it would be a very small effect.
What age are you seeing loss of diagnosis typically, or does it vary?
So the question is, what age are they losing the diagnosis?
Mm-hmm. Yeah.
So, So my first paper on this topic actually was a case series of kids who started out clearly on the autism spectrum and then moved to ADHD, which is a common pattern. And then some of those kids lose the ADHD, and some of them continue to struggle with, the attention problems. And in that paper, the average age at which they lost the diagnosis was 7. But that's not really firm because I don't take away the diagnosis until I'm really sure they don't need any more services. So I don't want to have them prematurely losing services. So I would, talk about a history of autism and some of the residual features they have. So if I actually, and then maybe I didn't see the kids for 2 years. So I think that 7 is probably a little high, And the range is probably, I think, 4. So in the Moulton paper that I just mentioned that's in press now, she was looking at kids who had lost the diagnosis after 2 years, mostly of ABA, and they were age 4. And then I don't know what the upper age range is, but I can just, from my clinical experience, I would say that if a kid hasn't really made very significant language and social gains to the point of being, maybe nerdy, maybe a little odd, but really functioning very well by the age of 12, then it's not likely that they're going to really wind up indistinguishable from typical individuals. But that's not data, that's just my clinical experience.
In terms of the ABA receiving group, were there differences in the kind of ABA they were receiving, or was it the same ABA?
Well, so there's a lot of different ways of talking about ABA, and I've seen, I think for me, there's intensity is one variable that's really important. So if you're getting an hour a week of ABA, forget it. That's not going to do much of anything. There's a lot of data showing 40 hours, and then there's some more recent data, particularly with young kids, showing that 15 to 20 hours might be good, especially if parents can then work on generalization and do a lot of reinforcement of the things that you're trying to teach the kid. So that's one variable. The other variable that's probably as important is good ABA and bad ABA. And it's really hard to characterize that. And when you're asking parents about the kind of therapy that their kid got 10 years ago, it's not possible to find out if it was good ABA or bad ABA. And what I mean by good ABA is like the therapist that you saw in the little clip of Wells. Lots of emotion, lots of positive emotion, lots of enthusiasm, lots of seeing when the kid is getting bored and switching what you're doing, lots of making sure that what you're using for a reinforcement really is a thing that's preferred by the kid, and not trying to teach things that the kid already knows and is going to be bored, and not trying to teach the kid things that are, way above their current level. But, it can be hard for parents to figure out, whether the ABA their kid is getting is, really good or really bad. I've seen clips of ABA therapists where I'm just wincing through the whole thing, where the therapist is like projecting, I'm so bored, you're so bored, let's get this done so we can go do something interesting. Now, that's the opposite of what you want.
When you're seeing the psychiatric comorbidities, particularly ADHD, why do you think there's such a high incidence of ADHD amongst this group?
Yeah, I think that's a great question, and I don't know the answer, but my best guess is that there is a tremendous comorbidity to start with, and probably because attention problems are central to autism, even though they're not in the diagnostic criteria. And Marcel Kinsborn, who's a wonderful neurologist, brilliant neurologist, really thinks that a lot of what is the central part of autism is that the kids are focused on their internal state and internal thoughts, and less on what's going on in the outside world. So when you're trying to get the kid to do a task that you want them to do, and they're, you see these kids a lot, and they're trying, some of them, they're real sweet, and they're trying to be compliant and give you what you want, but they can't get their attention disengaged from what's going on inside and focus on the task. So I really think that attention is central to autism, and it's hard to remediate, and it's often not a focus because you want to get the kid more compliant and you want to get them more social and more language, and maybe those things are actually easier to remediate. So what they're left with is the attention problems, which kind of fits the criteria for ADHD.
Okay, thank you. I'm afraid that's all we have time for today. If you didn't get to have your question asked to Professor Fein, then you can ask it in the comments section on our website. We'll be posting a complete replay of the presentation soon. Should be there by Friday. It'll also be posted on our social media and on our YouTube channel. This webinar is part of an ongoing series, so please check in on our site for upcoming talks and for video archives of previous webinars. Thanks again, Professor Fein, and thank you all.